morning friends, welcome back. I hope you are enjoying my videos, and today we are back with a very nice video. So before starting my video, I just want to tell you, it doesn't matter what others are doing, it matters what you are doing. So it is very important. And why I want to share this, because I myself as a student, I used to be caught up, I always was something in my mind, okay, what others are reading, okay, which book they are reading, okay, what they are doing. No, don't do that. Okay, do what suits you, do what is best for you. Some people might wake up in the morning and they might read at 5 o'clock. Some people might like to read whole night. Some people are better at reading at library, okay, instead of reading in the room. So my saying is that life is different for different people. So do not blindly follow others. Just because someone is waking up in the morning and reading, okay, it doesn't make your reading at late nights something bad. So don't copy others blindly. Okay, use your own self, do something that is best for you. So with this particular note, I want to start off, and myself, Dr. JIBRAN, presents to you Simply Pathology, and today we are back with very important lecture, that is SLE Part 2. Hope you have enjoyed Part 1. So in this particular lecture, we are going to read about the ETIO-PATHOGENESIS of SLE. So what are the factors that we are going to read about? So there are genetic factors, immunological factors, and there are environmental factors. Please note that this is a very important topic, and it comes in exam questions in the colleges very frequently. Also these are and will be asked, okay, in your NEET-PG, in your next exams, in your AIMS, USMLE, PLAB, all these exams of national importance. These are very important topics. So stay tuned till the end of the lecture. Okay, so the fundamental defect in SLE is the failure of mechanisms that maintain self-tolerance. And as we saw, there are three basic mechanisms. There are genetic factors, immunologic factors, and there are environmental factors. Okay, so if you see, what are the genetic factors? Okay, what are the genetic factors? So SLE has a genetic predisposition. Okay, meaning, okay, that there is a genetic component, okay, that regulates SLE. Now SLE is multigenic, so there are multiple genes which are regulating SLE. Now these genes, they can be HLA or they can be non-HLA genes. Now 20% of the clinically unaffected first degree relatives of the SLE patients, they develop or they have autoantibodies. What is the meaning of this? The meaning is that if there is a patient of SLE, a diagnosed patient of SLE, now their first degree relatives, okay, 20% of these first degree relatives, they have autoantibodies without any symptoms, means they are going to develop SLE in the later life. Okay, now one important MCQ over here is the HLA-DQ locus. This locus is very important, and this particular locus, that is HLA-DQ locus, is associated with the production of anti-double stranded DNA, anti-Smith antibody, and APLA antibody. Okay, now there is a very high probability of SLE in monozygotic twins when compared to dizygotic twins. So for example, if there is a monozygotic twin, then the risk of SLE is 20%. Okay, but in case of dizygotic twins, the risk of developing SLE is 1 to 3% only. Now one very important part is that in our body we are having certain complement components, especially the early complement components like C2, C4 or C1q. Now these particular components, they are involved in clearing the immune complexes from our circulation. So this is the normal function of the complement component. But what happens in case of SLE, there is a deficiency of C2, C4 and C1q. So what will happen? The immune complex, they are not cleared from the circulation, and they will go and get deposited in the tissues. Okay, so also there is one more concept over here. The deficiency of C1q, okay, is associated with a defective phagocytosis and clearance of apoptotic cells. Okay, so remember the complement components like C1q is also involved, okay, in clearance of the apoptotic cells. So remember, whenever there are certain cells in our body which are dying, right, by apoptosis or by necrosis or whatever, so these dead cells, they have to be cleared. Okay, they have to be removed from the body. So what happens that this C1q is responsible for that particular function. So when there is a deficiency of C1q, there is a defective clearance of these apoptotic cells or the dead cells. So what will happen? So if there is a persistence of the nuclear components of these apoptotic cells, so what will happen? They are going to induce an immune response, and that is going to lead to autoimmunity against the nuclear antigens. So understood? So if the dead if the nuclear material of the dead cells or the apoptotic cells, they are not cleared because of deficiency of C1q, what is going to happen? Our immune system is going to recognize that particular nuclear antigen and will start to develop antibodies against those particular antigens. Okay, so now we are going to discuss the immunological factors, okay, that is causing SLE. So the immunological factors, if you see, number one, as we already saw, there is a failure of self-tolerance in the B cells due to the defective elimination of self-reactive B cells. As we have already read the immunological tolerance, we have discussed the mechanisms, okay, how the B cells are being, how the self-reactive B cells are removed from the circulation. So over here, there's a defective elimination of self-reactive B cells. Now also there is activation of CD4 plus T cells which are specific for nucleosomal antigen. Now as you have seen the previous lecture, I have explained you the structural organization of the nucleus, wherein what is a nucleosome? A nucleosome is nothing but, okay, it has a central core of histone, which is a very conserved region which is packed around by a segment of the DNA. That is called as a nucleosome. Okay, we have already read. So over here there is activation of CD4 plus T cells specific for nucleosomal antigen. Now remember one thing, that the nuclear DNA or the RNA which is present in the immune complexes, okay, via engagement of the toll-like receptor. Now this toll-like receptor is present on the surface of B cells or maybe on the surface of dendritic cells. So via the engagement of toll-like receptors on the surface of the B cells, it is going to cause activation of the B cells. So immune complexes via toll-like receptors on the surface of B cells is going to activate the B cells, which will lead to production of anti-nuclear autoantibodies. Okay, so there is a very important role of toll-like receptors, okay, in the production of autoantibodies. It is via these receptors that the nuclear antigens are stimulating the B cells. Okay, now the fourth important point under immunologic factors is that type 1 interferon is playing a very important role in the pathogenesis of systemic lupus erythematosus. Remember that normally the microbes, okay, the microbes, they engage the toll-like receptors. Okay, normally the microbes are going to engage the toll-like receptor, okay, but the nucleic acids in the body, they mimic the microbe and they can also stimulate the toll-like receptors present on the surface of the dendritic cell. Okay, they can also stimulate the toll-like receptors which are present on the surface of dendritic cell, and once the dendritic cell is stimulated, there will be an increased production of type 1 interferon. Now this type 1 interferon, once they are produced, they are going to further stimulate the B cells, dendritic cells and T helper 1 cells, and this will lead to the production of pathologic autoantibody. Okay, so this is the basic mechanism, okay, how type 1 interferon, okay, is involved in causation of production of autoantibodies. So these are the four important mechanisms of immunological factors. Okay, now we are going to read about the environmental factors. So what are the environmental factors? The third important part. So environmental factors, number one is the ultraviolet radiation. Now a lot of MCQs are being asked from this part, so please pay attention. See, UV radiation, they can increase the apoptosis, okay, and when apoptosis increases, okay, there is an excess of nuclear remnants, as you know, because now there are dead cells, so dead cells will be having excess of debris which is composed of nuclear components. Okay, now these nuclear components can elicit an immune response, as we already discussed. Second, the ultraviolet radiation can also alter the DNA in such a way that its recognition by the toll-like receptors is enhanced, okay, and that will lead to increased amount of immunogenicity, ultimately leading to immune response. Thirdly, there is a modulation of the immune response. Okay, the UV radiation, they can stimulate the keratinocyte to produce interleukin 1 that itself, you know, is involved in inflammation and immune response. Okay, so three important points under UV radiation: increased apoptosis, you alter the DNA and make it more immunogenic, and thirdly, you stimulate the keratinocyte to release certain cytokines like interleukin 1 that is going to cause inflammation. Now the second important environmental factor is the gender. There is a gender bias. Okay, why we see that SLE is far more common in women as compared to men? Because of the effect of estrogen and also because of some undiscovered genes which are present in the X chromosome. Moving ahead, the third important environmental factor are the drugs. So certain drugs, for example, hydralazine, procainamide and penicillamine, they can cause SLE-like response. Okay, Now, few important points. Remember that SLE is closely associated with Epstein-Barr virus, smoking, silicosis, as well as ultraviolet radiation, UV rays. Plus, there is a mutation in a TREX1 gene which is involved in DNA repair on the X chromosome, is also associated with the development of SLE. Okay. Now we are going to discuss a very important model for the pathogenesis of SLE. Now just before this we have discussed the ETIO-PATHOGENESIS. Okay, etiologically what is the cause? Now we are going to discuss we are going to take all the factors together and we are going to see how SLE is being caused. A model for the pathogenesis of SLE. So before I go over there, I will just like to tell you one basic concept. Toll-like receptors are basic receptors of the innate immune system, and the normal function of the toll-like receptor, it is to sense the microbes. But in case of SLE, what is happening? The nuclear antigens which are resembling the microbes, okay, they start to stimulate the toll-like receptors, okay, and because of that there is a downstream signaling and there is an immune response. This is what is happening in the SLE. Our body, okay, that is the toll-like receptor of our body, okay, they are mistaking the nuclear antigens for microbe. They are thinking that the nuclear antigens, they are the microbes and they are acting against them, okay. So now let us see. So very important, for example, there can be the susceptibility gene. As we have already spoken about, there are certain susceptibility gene. In the first lecture you must have seen. Now these susceptibility gene, they cause the B and T cells, okay, they cause the production of those B and T cells which are specific for self-nuclear antigen, that is the antigens which are produced in our body. And secondly, the external triggers like the UV rays, they stimulate apoptosis, as we have already seen. And when there is a defective clearance of apoptotic bodies, for example in cases of C1q deficiency, there will be an increased burden of nuclear antigens. So on the one hand we are having the lymphocytes which are specific for the self-nuclear antigen, and on the other hand we are having an increased burden of nuclear antigen. So what is going to happen? These lymphocytes are going to produce certain anti-nuclear antibodies, and that antibody is going to interact with the nuclear antigens, leading to the formation of antigen antibody immune complex. Now finally what is going to happen? Now these anti-nuclear antibody complex, okay, they are going to be endocytosed into the B cells and the dendritic cells. So there is an endocytosis of antigen antibody complex and the toll-like receptor engagement by the nuclear antigen. So what is happening? These antigen antibody immune complex, they are entering the B cell and the dendritic cell, and now they are engaging the toll-like receptor. As I already mentioned, if the toll-like receptor is stimulated, they are going to misinterpret these immune complexes as microbe, and then they are going to trigger a reaction. So from the dendritic cells, what is happening? The toll-like receptor is stimulating the B cells and dendritic cells. So how they are stimulating it? Now these toll-like receptors, when they stimulate the dendritic cell, they also cause the release of type 1 interferon, and as you know, these type 1 interferon is going to stimulate the B cells, okay, as well as the T cells, okay, and that will lead to the production of persistent high level anti-nuclear IgG antibody production. Remember, the type of antibody is IgG in nature. Okay, so this is the basic, the summary of the pathogenesis of SLE. So this is a very, very important diagram. If you just write this, if you just produce this in the diagram in your exams, you are going to get full marks. Okay, now moving ahead, if we are reading the mechanisms of tissue injury in SLE, again it is very important. There are several mechanisms. For example, number 1, immune complex mediated tissue damage. This is nothing but type 3 hypersensitivity reaction, and this is the most common mechanism of tissue injury in SLE. The second is autoantibody mediated destruction of the blood cells. So some of the reactions in SLE are type 2. This is type 2, that is antibody mediated destruction. So this is type 2 hypersensitivity reaction. And the third is anti-phospholipid antibody syndrome, which we have discussed in details already, and then the neuropsychiatric manifestations of SLE. So without wasting any time, let us move ahead. Now the mechanisms of tissue injury, that is the first part. Remember that most systemic lesions in SLE, they are caused by deposition of immune complexes, and this is a type 3 hypersensitivity reaction. Also, one important MCQ, this is the most common mechanism of tissue injury in case of SLE. So see over here, we are having an immune complex. Immune complex is made up of antigen reacting with an antibody, and over here the antigen is a nuclear antigen. So these immune complexes, they are going to go and deposit in the glomerulus, in the kidney and the blood vessels. Okay, and also these immune complex, they are causing activation of the complement system. and these complements, they are also going to get and deposited in the immune complex. Okay, so this will lead to the consumption of the complement proteins. Ultimately, the levels of serum complement will come down, so there will be a low level of serum complement in SLE. Okay, and there will be immune complex deposition in the tissues, and if we see under immunofluorescence or under the immunofluorescence microscope, we can see that there is a granular deposit of complements as well as antigen antibody complex. There are many immunohistochemical markers which can demonstrate the presence of complements as well as antigen antibody complexes. Okay, so this is one important part, the type 3 hypersensitivity reaction. Now this is not over. Now one thing that I want to mention you, and this is very, very important from your MCI exams or FMG exam or the various competitive exams also, you have to have the concept of LE bodies or hematoxylin bodies. So what happens when an anti-nuclear antibody, okay, is reacting with an exposed cell nucleus? Suppose there is a cell and the nucleus of the cell has been exposed. Now already in the body there is an anti-nuclear antibody. Now what will happen? That particular antibody is going to react with that particular nucleus. So nucleus of the damaged cells, okay, once they react, once they destroy the nucleus of the damaged cells, they lose their chromatin pattern. So see, normally the chromatin pattern is like this, but because of destruction, because of damage, they became somewhat like this. That is homogeneous, and this is abnormal. Okay, this homogeneous pattern is an abnormal pattern. Okay, so this damaged homogeneous nucleus, this nucleus is called as the LE body or hematoxylin body. So this is the nucleus, okay, which is homogeneous, and this is called as the LE body or hematoxylin body, which has been asked in exams repeatedly. Okay, so this is very, very important MCQ. Now to go further, now this LE body, okay, when it is phagocytosed by a leukocyte, for example a neutrophil or a macrophage. So when they are phagocytosed by the leukocyte, like a neutrophil or macrophage, something like this happens. And this particular leukocyte which is engulfing or phagocytosing this LE body, this is called as an LE cell. A very, very important concept repeatedly asked in the exams. I will give you all the images in Simply Pathology in my Instagram account. Okay, just follow my Instagram account, you will find all these images. Now what is the differential diagnosis of an LE cell? Okay, I had given one image in my community tab post regarding this particular part. So the differential diagnosis of a LE cell is a TART cell. So what is the difference between the two? So here also there is a macrophage or a monocyte which has engulfed a nuclear chromatin, but here the nuclear chromatin is not damaged, it is intact nuclear chromatin. You can see the striations of the chromatin. So this particular leukocyte which is having or which has engulfed a preserved intact chromatin, this is called as a TART cell. Okay, and this is very important concept. Okay, so over here the neutrophil or a macrophage which is causing, and here there is a macrophage or a monocyte. So a neutrophil or a macrophage causing phagocytosis of homogeneous damaged nucleus, that is called as a LE cell, whereas the same leukocyte or a macrophage causing phagocytosis of a preserved intact nuclear chromatin like this is called as a TART cell. A very, very important concept. Now demonstration of the LE cell in vitro was used in the past as a test for SLE, but now it is a historical test. It is no more used. There are many other assays, okay, which are used to determine the levels of anti-nuclear antibodies. Now LE cells are found in pericardial or pleural effusion, okay, in patients of SLE. Okay. Now, coming to the second important mechanism of tissue injury, as I already mentioned, autoantibody mediated destruction of blood cell. Now, the concept is very, very easy. If you have seen my previous lectures on basic inflammation, you are going to understand. Okay, so here there are autoantibodies which are going and tagging the RBCs, WBCs and platelets. Means they are going and they are opsonizing or tagging them like this. Okay, so what happens that they have been marked. Now the phagocytes, the blood cells are tagged. Now they will be ingested. They are now tasty target for the phagocytes. So this will lead to the phagocytosis of these particular RBCs and the destruction leading to cytopenias. Okay, which is very common in SLE. As you've already seen in the clinical criteria, there is one hematological criteria also. Okay, showing your hemolytic anemia, hemolysis of the RBCs, showing your lymphopenia and showing a thrombocytopenia. Okay, now moving ahead, remember this autoantibody mediated destruction of the blood cell is mainly an example of type 2 hypersensitivity reaction. It is most common disorder due to the above hypersensitivity reaction, that is because of antibody mediated destruction, is ITP. So out of all the example, the most common disorder due to the above type 2 hypersensitivity reaction is ITP. ITP stands for idiopathic thrombocytopenic purpura, wherein there is a destruction of the platelets by binding of the autoantibodies to the platelet surface glycoprotein, and once these platelets have been tagged by the autoantibodies, there is removal of such platelets by the macrophages which are present in the spleen, and that is going to lead to thrombocytopenia. Okay, so this is the most common disorder because of autoantibody mediated destruction, that is the destruction of platelets, ITP. Okay, now the third important part is anti-phospholipid antibody syndrome. The third important mechanism we have already discussed in details about the APLA syndrome. Now here what is happening, the patients of SLE with APLA antibody, okay, they are basically presenting with recurrent thrombosis, recurrent spontaneous miscarriage, and cerebral ocular ischemia. Okay, so just remember one thing, I am going to repeat once more. Now in this APLA antibody syndrome, what happens, inside the body, that is in vivo, the patient is presenting with recurrent thrombosis. There is a prothrombotic nature, but paradoxically in vitro, that is outside the body, if you take the blood of such patients, okay, the clotting is impaired. Okay, the clotting is impaired. There is a prolongation of prothrombin time as well as partial thromboplastin time. So this is a paradox, and which is only and only seen in APLA syndrome. So inside the body there is increased thrombosis, outside the body there is increased bleeding, okay, in the test. So APLA alone is the primary APLA syndrome. APLA along with SLE is called as secondary APLA syndrome. Now the fourth important mechanism is neuropsychiatric manifestations of SLE, which is because of the autoantibodies which are crossing the blood-brain barrier and which are reacting with the neurons or the receptors for the neurotransmitters. Now the neuropsychiatric features are associated with which antibody? This is again important question, with the anti-ribosomal P antibody. Okay, now we are going to end with this particular last part, that is the drug-induced lupus erythematosus, which is a very important short note, plus it is asked in several competitive examination repeatedly. So drug-induced lupus erythematosus, so drugs which are causing such reactions, they are hydralazine, procainamide, isoniazid, and D-penicillamine. Now patients who are actually presenting or who are suffering from drug-induced lupus, they are mostly asymptomatic. Okay, now HLA-DR4, they are at patients who are having the haplotype, that is HLA-DR4, they are at a high risk with hydralazine, whereas patients who are having HLA-DR6, they are at a higher risk with procainamide. Now antihistone antibodies are diagnostic, okay, a diagnostic feature of drug-induced lupus. Remember that in MCQs they are going to ask you this particular question, that which antibody is most common in drug-induced lupus erythematosus. The answer is antihistone antibodies. Remember that anti-dsDNA antibody is rare. Okay, now renal and CNS involvement is also very rare in case of drug-induced lupus erythematosus. Now most patients, they develop anti-nuclear antibodies, but they are asymptomatic, as I already discussed. Remember, the disease is going to remit after withdrawal of the drug. Now just to revise the most commons in case of SLE. So the most sensitive antibody was anti-nuclear antibody. The most specific antibody was anti-Smith antibody. If the most sensitive as well as specific is anti-double-stranded DNA antibody. The most specific antibody in neonatal lupus with congenital heart block is anti-Rho and anti-LAB, both of them, but more commonly anti-Rho, SSA. Now the most common antibody in drug-induced lupus is anti-histone antibody, already discussed. Neuropsychiatric features in SLE is associated with anti-ribosomal P antibody. Raynaud's phenomenon in SLE is associated with anti-ribonucleoprotein antibody. Now shrinking lung syndrome is characteristically associated with anti-Rho antibody, and antibody in SLE now which antibody predisposes to photosensitivity in SLE? It is the anti-Rho antibody, that is SSA antibody. Okay, now for images refer to Simply Pathology, please. Okay, because of copyright issues I have shifted all the images to Instagram. Okay, please stay tuned for more lectures, and thanks for watching. Please do like, share and comment if you like the videos, if it has helped you in any way. Please do comment if you have any kind of doubts. Okay, thank you very much guys for watching this lecture. Stay tuned for further lectures. Myself Dr. JIBRAN presents to you Simply Pathology. Thank you.